And second speaker is Dr. Udara Jayawardena. He is a specialist in subfertility. So I leave it to Shamoon to start the session. Thank you. Shamoon, can you hear me?
Awanin lang කරන්න
Good evening. Due to a technical glitch, we will start with the second presentation for today. So our lecture from the second speaker is by Dr. Udara Jayawardena, who will be talking to us on tubal factor infertility, its assessment and management. Dr. Jayawardena is a consultant obstetrician and gynecologist at the Colombo North Teaching Hospital, Ragama, currently working as the acting consultant in subfertility. He has obtained his primary MBBS and MD in Sri Lanka. Dr. Jayawardena has also achieved the fellowship in reproductive medicine from Cambridge, UK. Over to you, Dr. Udara.
Okay, thank you very much. Thank you for the kind words, Shimon. So my topic is on tubal factor infertility. I will be briefly speaking on the assessment and the management. So we know that subfertility is becoming a bigger problem now. In the worldwide, it is estimated that about 10 to 15% of our couples are subfertile. And out of those, we can identify a cause in about 80% of the patients. And 20% we can't find a cause in basic investigations, and they're known as unexplained infertile couples. And out of the people who we can find causes, we can divide them into female-related causes and male-related causes. And out of the female-related or female factor infertility, ovarian and the tubal factors are the more prominent causes. So today's topic, the tubal factor, is estimated to have an impact on about 25 to 35 couples who face subfertility. And mainly we're going to talk about the tubal obstruction and hydrosalpinx in this lecture. So considering the tubal obstruction, the commonest cause of obstruction is infection. And primarily and most commonly, it's caused by the chlamydia trachomatis, but other infections like Neisseria also can give rise to tubal blockage. In addition to that, polyps, mucosal debris, tubal endometriosis, peritubal adhesions, and past tubal surgeries also do contribute. So the location of the tubal obstruction could be proximal, it could be in the mid-tube, or it could be in the distal tube. Proximal tubal blockage accounts for about 10 to 15% of tubal factor infertility. And it is actually described as a block that is closer to the uterus. And this can be easily treated nowadays hysteroscopically by cannulation. The mid-tubal blockage was commonly due to scarring. It could be because of a previous surgery like a sterilization procedure. It could be due to surgery for ectopic pregnancy and also unsuccessful attempt of surgical reversal of sterilization are the common causes. The distal tubal blockage is the commonest tubal the commonest tubal blockage we detect is the distal tubal blocks. It is further away from the uterus, and fallopian tubes could be partially or completely blocked at the distal end. And this also can be treated either laparoscopically or by laparotomy. But nowadays, what they say is even after correction of distal tubal disease, the chance of pregnancy is comparatively less after treating when it's compared to after treating a proximal pathology. So assessment of tubal patency. The commonly practiced tests for tubal patency are the laparoscopy, there are HSG, which is the hysterosalpingography, and the HyCoSy. HyCoSy is the hysterosalpingo contrast sonography. The other tests, the Rubin, the saline infusion sonography, and phalloscopy, they're not routinely practiced nowadays. So laparoscopy is the gold standard test. So the advantage of laparoscopy include, it has a higher sensitivity, higher specificity. There is a simultaneous assessment of the pelvic cavity and organs could be performed. And also there is a potential for therapeutic intervention. The disadvantages are, there could be complications related to the invasiveness as well as due to anesthesia. It is more expensive, and we also may need to admit the patient to the hospitals, especially in our setup. HSG is the visualization of the uterine cavity and the fallopian tubes by injecting a radio-opaque contrast medium, and it has a sensitivity of 84% and a specificity of 74.5 when compared to the gold standard laparoscope. Advantages are, of course, it's an office procedure. It's easy to perform. There's no need of anesthesia. Relatively good sensitivity and specificity. And also you can find the site of the obstruction. Disadvantages are it is less sensitive compared to laparoscopy, cannot assess the pelvic cavity, and there is no therapeutic intervention possible in a HSG. So I have brought some examples, HSGs, which indicate different types of obstructions. In the first one, of course, you can see the dye has not passed from the conal end in the right tube. It's a proximal tubal obstruction. The second one is, of course, a patient who had a sterilization procedure. So the dye has gone partially in the tube, but you can't see any dye in the distal end or spillage. The third one is a distal block. So it also has hydrosalpinx in both sides. So that is an additional advantage in HSG. You can also detect hydrosalpinx from the procedure. Hycosis. So this is something increasingly practiced, especially in the Western countries, because of its advantages. So now in Western countries, what happens is the patients have to go for, they have to take different appointments for scan, different appointment for the procedure hycosis, and then they have to come back again to the clinician. But if they perform the hycosis, all these three things can be done at the same time, because the procedure will be performed by the clinician. Clinician will be doing a scan followed by the hycosis, and then the clinician will be able to give a plan at the same time. So it saves a lot of time, and it is becoming increasingly popular in the Western world. What happens is it's very similar to the saline infusion sonography. We have to pass a pediatric catheter through the cervical os into the cavity, and we have to inject a contrast. It's actually a medium that contains microbubbles, and when it is injected in the scan, we can detect the uterine cavity being filled, and then the bubbles passing through the tube and coming out of the fimbrial end. And it is also having a very good sensitivity and specificity comparable to HSG. So the advantages of hycosis, it's again an outpatient procedure, less time consuming. We can do the scan at the same time. There's no exposure to the radiation, and also has a reasonable sensitivity and specificity. Disadvantages, less sensitive and specific compared to laparoscopy. Again, we can't assess the pelvic cavity and does not have a therapeutic intervention that can be done at the same time. So there is a small video. I don't know whether I can play the video. Yeah, so you can see. So the thing that you can see as the white material is the liquid that we inject. You can see the cavity getting filled inside, and then it goes through the conal end, through the tube, and distally, you can see the dye, the contrast medium coming out. What we used for hycosis is actually a liquid called XM foam. There are different liquids available in the market, and these contain the microtubules. One thing that we can adopt in our setup is that we can sometimes use the saline, and then if we shake the saline, we can create small air bubbles. So similarly, we might be able to see air bubbles going through the tube. This is like a modified hypoxia. So the management of tubal block. Nowadays, of course, because of IVF, the tubal surgeries have become less important because IVF, of course, give much better results, and the time duration the patient has to wait to have a baby is much less. So most of the patients tend to go for IVF, and clinicians tend to offer IVF. But of course, if IVF is not freely available and if it's not an option, tubal surgery is a alternative option we can look for. So tubal surgery. So tuboplasty, they're like fine surgeries on tubes with the aim of restoring the anatomy as far as possible. We can do it as a microsurgical procedure. And if it is done as a microsurgical technique, it gives better results because of the lower tissue damage, less tissue handling, and better hemostasis as well as minimum adhesion formation. If an open operation is chosen, it has to be, and it should be performed through laparoscope or by a conventional open microscope technique. So conventional open surgeries nowadays not practiced unless it is combined with the microsurgical technique. And nowadays, clinicians tend to perform more and more laparoscopic tubal restoration surgeries as well. And prospective randomized studies are not available to compare the results of distal tubal obstruction, which is treated by laparoscopy or open microsurgery. So when we recommend tubal surgery, we have to take some other things into consideration as well. We have to think whether restoring tubal patency will improve the chances of that particular couple having a child. So we can recommend tubal surgery for a younger woman, and also if there are like any other coexisting pathologies are minimum, like for example, if there is endometriosis, if it's severe, better not go for tubal surgery and offer IVF. But if the endometriosis or any pathological condition is less in severity, then this is an option we can look for. And depending upon the site of the block, they have been associated with successful pregnancy rates, varying from 27% for femoral surgery, ranging to 50 to 60% for ischemic block. So indications of tubal surgery: peritubal adhesions, proximal, mid, and distal tubal blocks. Types of tuboplasty surgeries: it could be fibroplasty, it could be salpingostomy, tubal anastomosis, tuboconval anastomosis. Fibroplasty, this can be done laparoscopically. In fibroplasty, what we do is we separate the fimbriae in that is fibrolysis, sorry. In fibroplasty, if the abdominal opening is phimotic but patent, then we can improve the patency by performing a fibroplasty. In the milder forms of distal tubal occlusion, the pregnancy rates have to be reported up to 60%, but still the success rates are lower at 10 to 35% with the distal severe tubal disease. But if there is coexisting tubal pathologies, proximal and distal both, then of course the pregnancy rates are much lower. Salpingostomy, it is creating an opening in a completely obstructed tube. And salpingostomy also yields very comparatively lower long-term pregnancy rates, which is about 20 to 30% in 1 to 2 years after surgery. And the ectopic pregnancy rates increased, and it ranges from 4 to 25%. So tubal anastomosis is performed especially for the mid-tubal blocks for like tubal sterilization. So the advantages of surgical tubal reanastomosis are the chance of natural conception is possible, and there's a lower possibility of multiple gestations when compared to IVF. But the disadvantages are there could be potential tubal scarring from the surgery itself. And there will be longer duration the patients or the couple has to try to achieve a conception. And there's a higher risk of ectopic pregnancy. And also after pregnancy, they have to go for contraception because the tubal patency is now established after surgery. So this surgery can be performed laparoscopically and also by laparotomy. And the prognosis of achieving live birth after reversal depends on few factors. It depends on the patient's age, the location, and the type of the sterilization, and also the final length of the repaired fallopian tube. The success rates are better in younger women with no other infertility factors, and if the sterilization was performed with rings or clips. And overall conception rates are good, more than 60% after microsurgical sterilization reversal. However, the risk of ectopic pregnancy after tubal reanastomosis is up to 6%. Tubal cannulation. This is done for proximal tubal block, and it can be done hysteroscopically combined with laparoscopy. And also, it also can be performed with selective salpingography. So the people who have had tubal cannulation, the average pregnancy rate is around 30%. And there was a systematic review of observational studies which showed that the hysteroscopic approach is superior to the selective salpingography and cannulation. So the pregnancy rates after hysteroscopic procedure was 29% compared to 21% after salpingography and cannulation. The risk of perforation is around 5%. The risk of ectopic pregnancy between 3 to 6%. Tubal condual anastomosis. This is not a very common surgery nowadays. And there's another surgery called tubal reimplantation. That is, if the proximal tubal block cannot be relieved, then the tube can be reimplanted into the uterine cavity. I think these surgeries mostly have historic value now. Nowadays, we don't practice that. We prefer to go for IVF. So IVF versus tubal surgery. Yeah, this needs to be discussed with the couple because IVF is anyway a costly procedure and it may not be freely available to us and the patients may not be able to afford it. However, the success rates of IVF, as I said before, are much higher and the time duration they have to try for a pregnancy is much shorter. But if it's a tubal restoration surgery that we decide to offer the patient, they need to be aware that they may have to try for a longer time and the success rates are not improved compared to another person who has a normal tubal patency. And along with that, the risk of ectopic pregnancies also increase. And also if they do not succeed after tubal restoration surgery, again, the final offer would be IVF. So hydrosalpinx, it's a collection of fluid in one or both of the fallopian tubes. And any distal tubal occlusion can lead to the formation of hydrosalpinx. But the main cause for that is the infections like chlamydia trachomatis, which causes PID and associated tubal damage. And 10 to 30% of patients who are going for IVF and embryo transfer may be having unilateral or bilateral hydrosalpinges present. A salpingectomy prior to IVF procedure significantly improves the outcome of the IVF procedure by increasing the chances of live birth rates by about more than twofold. So the effect of hydrosalpinx on fertility, presence of hydrosalpinx is associated with a lower implantation rate, lower pregnancy rates, even after IVF. There was a large meta-analysis of cases with women who have had hydrosalpinx, and they have found that it halves the pregnancy rates, halves the implantation and live birth rates after IVF. So, and in addition to that, the spontaneous abortion rates and the risk of ectopic pregnancy also rises. How does it act and how does it reduce these chances of pregnancy and reduce implantation? There could be cytotoxic effects if there's backflow of fluid that is in the hydrosalpinx, because these fluid also may be containing some toxic material that can have the effect on the embryo. There could be leakage of fluid into the uterine cavity, and the action of the fluid also be on the endometrium that can decrease the receptivity of endometrium to the embryo. And also there is a mechanical effect, like it can wash off the blastocysts from the endometrial surface. Therefore, it can reduce the implantation rate. So the treatment, important thing is, if there is a hydrosalpinx, especially if it's for a couple who's waiting for IVF, the best thing is to either do a salpingectomy or to do a proximal tubal occlusion by laparoscopy. You can drain the fallopian tube, but these fluid tend to reaccumulate very quickly. So it is not a very effective treatment method because in IVF, we are putting an embryo back into the uterine cavity. The chances of implantation is much higher. So therefore, we need to increase these chances by further, by managing the coexisting problems that can have impact on the embryo. Therefore, the best thing is to do either a tubal occlusion or a salpingectomy for these patients awaiting IVF. So there was a multi-center prospective RCT, which found significantly increased pregnancy and live birth rates, which were like 37% and 29% respectively in the salpingectomy group, when it's compared to the group which did not have intervention, and their pregnancy rates were 24% and the live birth rates were 16%. And there was a meta-analysis of 2 laparoscopic proximal tubal occlusion studies, which found that it also improves the clinical pregnancy rate. So both both tubal occlusion by laparoscopy and salpingectomy are more or less equally effective. And both are recommended for patients awaiting IVF. Thank you very much.
Thank you very much, Dr. Udara. We would like to take questions from the audience or from those who are listening in through Zoom. If you have any questions, please, you can send us a message on chat. Okay. We have one question.
I'm Dr. Senaratna from DMH. Okay. So this is my question on reversal of LRT. As you said, in our situation, IVF is not still established in government sector. So we need to consider, and with the cost of IVF, we need to consider reversal of LR in many patients who is subfertile, especially who are people on they have remarried. So is there any criteria to select them for reversal? Like one factor is age. Do we have to do AMH or antral follicular count or any other selection criteria to select the patient for reversal of LRT?
Yeah, yes, yes. I think in our setup, of course, first we need to make a decision whether the patient can afford IVF. If they're considering IVF, of course, we need to find out how successful the IVF could be. So in that setup, we may need to check the ovarian reserve with AMH and all that. But if they can't afford it and it's completely out of the scene, then of course, there's no point of going ahead. But they need to know that even after restoration of the tubal patency, if their age is high and if their egg reserve seems to be low, then their chances of having a natural conception after pregnancy, natural or either with IUI, is comparatively low when compared to a younger patient who's having a tubal reversal. Sorry, sir. Primary factor in our setup, because we don't need to investigate like in Western world, like we do all sort of tests in other patients, but we can't afford it. If we can, and if they are willing to do AMH, that's fine, because we can give more information to them on their chances. But otherwise, I think if they are firmly on surgery without going for IVF, then if we counsel with the clinical information we have, that should be enough.
For a patient who has had tubal sterilization and then now requesting, they can't afford IVF, so they're requesting tubal surgery. Sometimes we don't have the specifics of what type of tubal sterilization was done, given that different people employ different techniques, including fimbriectomy. So would you go with a laparoscopy first to
Yes.
decide
Yes.
routinely?
Or what we can do is we can counsel the patient.
Yeah.
That sometimes, because we don't know all the details about the previous surgery and we don't know about the current situation inside the abdomen, we might not be able to perform the surgery even if we plan to do so. So we have to do the laparoscopy and see whether we can see the proximal stump and if there's adequate distal segment and whether we can approximate them together. And if there is no significant pelvic disease, adhesions or severe endometriosis, then we can do it. But we have to always tell the patient that sometimes it may not be possible, depending on, because we don't have the full information. If we do have the information about the surgery, we can counsel them better. But unexpected things happen when we go in. So the patients need to be aware that sometimes may not be able to perform it completely. I mean, if you can at least restore the tubal patency in one side, that should be enough.
The patents tubes, but we are not sure whether they are functional. The tubal peristalsis is there or not? It is not there. Is there any test to assess that one?
As far as I know, there is no functional test we can use. We can predict the function, but there's no test as such to assess the functional capacity of the tube.
And my second question is the blocked hydrosulfing is worse than the patent hydrosulfings in terms of IVF or in terms of fertilization?
If you have a hydrosalpinx, it doesn't mean that the patient can't get pregnant. They can get pregnant, but the chances would be much less. So if it is obstructed, I think the prognosis is less. If it's an open hydrosalpinx, there is still a chance that a miracle happen and the patient can get pregnant. So it's better. But if you're going for IVF, irrespective of whether it's open or closed, better to do the salpingectomy or tubal occlusion. One thing about the tubal occlusion is some people prefer to do it rather than doing the salpingectomy because, I mean, there are some blood vessels that are running closer to the tube, which also supply the ovary. So we might be disrupting those vessels when we do the salpingectomy. So they believe that if we can leave those blood vessels intact, the ovarian response could be much better when the IVF stimulation is done. So they prefer to do just the diathermy, the proximal and cut it rather than just completely removing the tube.
Thank you.
What is the test that we can do? What are the most common tests that we can do after reversal to assess the patency, whether HSG or a Lapendia test?
I would prefer to go for HSG.
How long we should wait?
Maybe 2 to 3 months. That should be enough.
Thank you, sir.
Thank you very much, Dr. Udara Jayawardena, once again for that interesting lecture on tubal factor infertility, its assessment and management. We will now move on to the next lecture, the much awaited one by Professor Nishendra Karunaratne, who will share his expertise on the role of endoscopic surgery in ART. Over to you, Dr. Nishendra.
Thank you, Shamun, and thank you very much for the council and the college officials for inviting me for this small presentation about the role of the endoscopic surgery in ART. I'm mainly thinking of presenting of some practical points, and we all know of course, in all of our hospitals, we run the subfertility clinic. We might not be able to do the IVF in all the hospital, but still we go and manage the patient to the end, like at to the level of IVF, and then we have to do the endoscopic surgeries and the laparoscopic, mainly laparoscopy and hysteroscopy. So the value and the role of the laparoscopy and how we should do, or maybe get some tips and some kind of sharing experience would be, I think it's beneficial for all of us. When we talk about the endoscopy surgery, the role is, of course, it has a very big role in in IVF treatment and in advanced fertility treatment. If you want to have IVF lab or a IVF hospital or clinic, it's mandatory to have a good laparoscopic setup or the endoscopic setup and a skillful laparoscopic surgeon. And it's usually we use the endoscopic surgery in assessment of the patient, the cause, to identify the causes, and also mainly to the treatment. And so we do it mainly in hysteroscopy and laparoscopy. There are so many other small entities are there, but usually the hysteroscopy and the laparoscopy are the main two arms. And treatment, mainly, when you look at the success rates of the IVF, it's largely depend on the correct anatomy, the correction of the anatomy of certain conditions. In correcting anatomy and the embryo quality and the egg quality and everything will matter. So the correcting anatomy and having a good receptive female genital tract is offers something of paramount importance. So for that, we need endoscopy surgery and the corrective procedures. And also, as we know the assessment of the genital tract, especially the tubal patency, was largely done with laparoscopy. But I should agree, the gold standard to diagnosing the tubal patency and the endometrial laparoscopy. But with new imaging techniques, we can equally efficiently identify endometriosis and the tubal patency. Of course, in most of the clinics now, if there's anything that we could treat only, we use laparoscopy to identify the tubal patency or to confirm the tubal patency. If you have a good dynamic HSG machine, and we of course can have a HSG and can use HSG to identify tubal patency as equally to the laparoscopy. Here, as my previous colleague mentioned, it's less invasive and less expensive. It's the one most important factor in these days. The hospital costs are going up, and then even in the government sector, you can't have many surgeries, and then you can keep your laparoscopy for the essential surgeries. And hysteroscopy wise, it's a very essential tool. You can treat many conditions which could cause obstruction to the IVF, namely the polyps, submucosal fibroids, and uterine malformations, septa and adhesions, and lastly, to improve the endometrial receptivity and implantation, we can use the procedures like endometrial scratching. And just show you some videos for your interest. And this is an endometrial polyp. And what I want to show here is this is after curettage, and polyp was large, and I did a curettage and had another look, and still the polyp was there. And then we get is there a playback? Can we take? Playback is appearing here. Okay. How do you get it? Yeah, yeah. How do you get it? Okay. Yeah, put it in with this one. here what I want to mention is, we have seen the DNCs were done for the polyps, and then when you do the next scan, after that, this polyp is still there. DNC is not a proper way of treating the endometrial polyp. I understand hysteroscopies are not available in some centers, but still the hysteroscopy and the removal of polyp is the best way. And sometimes you might not be able to remove it only with the DNC and have another look. And if the root is there, especially the polyp situated near the corners, the cornual lens, then your DNC, the curette might not pick up the root. So then I have another look and then remove it with scissors. And yeah, submucosal plate again. Plate. Yeah. Yeah, submucosal fibroids also, and polyps and fibroids, and there's something that we have to think about, and whether we need previous one. Yeah, that one. Whether we really need fibroids and polyps before we go in for IVF or Subfertility treatment. I have come across, and all of us have seen, the patients had got pregnant with polyps, and if it's a small polyp, which we could see from the scan, it's not obstructing the cavity in a large extent. Of course, we can start with subfertile treatment, but of course, if you are going for IVF, because IVF we are selecting once after all the other measures have been failed, so it's better to remove submucosal fibroid. The fibroid is also you need little experience in removing with resectoscope. This fibroid is there in the cornual end, and the only 1/3 of the fibroid we could see outside. So the proper assessment, the ultrasound scanning, and knowing the depth and the extent on the fibroid, and have a good hysteroscopy machine, good video camera, the assisting staff, and also the anesthetist are all equally important in performing good laparoscopic surgery and removing fibroids which are not which are like situated mostly in the myometrium. So we go through this quickly. Labor, yeah. And when you do these procedures with time, you will get to know how to remove all the fibroid, and how to identify the space, the interface between the fibroid and the myometrium, and then you will get little, get little the pinkish color once these areas have been visualized when you are performing the surgery. Then you take that as a guide, and then direct your resectoscope along that plane, and then you just pull the fibers and cut in like you just making that plane available to your visual field will help you to remove the fibroid completely. So that is one important thing. Otherwise, you will leave a little bit of fibroid in the myometrium, and which could grow back again. Yeah, next one. Intrauterine adhesions and septa is also another thing that which cause obstruction to the uterine cavity. Here we have a patient with the cavities mostly obstructed with intrauterine adhesions after some procedures. So scan is very important, and then you know where you are. Sometimes this adhesions, removal of adhesions is very tricky, because you don't know to which direction you have to point out your scissors and all. Take up control. There. Yeah, so then you use your scissors and point in a way that you can identify the adhesive tissues. And one important thing that you can see here is adhesions they are pale and less vascular. But if you have some doubt about where actually you are directing, of course, you can combine this procedure with a laparoscopy as well. Otherwise, uterine perforation could be a complication. And so then if you know actually where the directions are to be the direction where your scissors has to be directed, at one point all of a sudden you will come into a space where you could identify the tubal openings, or maybe some normal endometrial tissues. Is of course the adhesions are there and the mid cavity. But sometimes you might not, but then you get a considerable amount of space. You create a space in the uterine cavity, and then to prevent the further adhesion, you may keep a IUCD inside and use some estrogen in the follow-up care. And then you come back and then you can assess the cavity later and see the growing, endometrium growing. Yeah. Here you get a still the same surgery. It takes some time and must be very patient. And but also you can't waste time on hysteroscopies because you're loading up the patient with a lot of fluid. And ultimately, here after resection of adhesions, of course you get some, it's not complete the normal shape uterine cavity, and then at least you get some space, and then you can try putting a IUCD and then try for ART treatment later. So you get a lot of blood vessels outside. When you meet blood vessels, that means you are going into the myometrial vascular area. You can diatomize with rollerball diatomy, and then can control the bleeding. In a you enter a transeptum, and the narrowing of the cavity is also another cause which you could find out in a patients with subfertility. The septum sometimes they are very thick, and sometimes the thin septum. Thin septum, of course, you can divide with hook, the bipolar hook or the monopolar hook, and then resection hook. But if it's very thick, in this case, removing scar tissue, you see the right conua here, and then in the middle of the uterus, it's been divided into two by a thick septa here. Then the left side is obscured. Yeah, that's the left side. And we use resectoscope, and then you can use whole the septal area, and then oh yeah, so then using the resectoscope, of course, you can remove the thick septal, and this actually a looking at the two conal ends, and you guide in with the conal openings, can remove the septa and get the space into the uterine cavity, and so then get a good space for the cavity. Yeah, so the lateral walls also can be expanded by using the diathermy hook, and we call it lateral metroplasty. And in other cases where you see the T-shaped uterus, where the uterine mid cavity is very thin, very narrow, the lateral metroplasty has been used to get the space, and in view of increasing the implantation rates. But there are some studies were done to compare the procedures, lateral metroplastic procedure and the non-metroplastic for the controls. So the results are not very encouraging. And some studies which say the metroplasty increased the implantation rates, but in some studies they say there's no uh, difference in pregnancy rates in both groups. Next one. The other times, if you have a patient with the repeated implantation failure and excluding all the other factors, of course, you can try the endometrial scratching. Scratching could be done in different ways, and using the probe also you can scratch the endometrium. But if you were to do a hysteroscopy to identify any intrauterine pathology like in intrauterine adhesions, at the same time, you can use scissors to do endometrial scratching to improve the receptivity of the endometrium. And I think we collected few cases in Lanka Hospital IVF Center, and we found, but even though numbers are not that large, we found the scratching helps a lot in the patients who had repeated implantation failures and who failed IVF procedures, IVF procedure in the past. But still the results are like very controversial, but there's a improving trend. Like they say the scratching could be used in the patients with previous failed IVF cycles. Then the laparoscopic procedures are mainly for the endometriosis, and as my colleague discussed, like hydrosalpinges and for the fibroids. And the endometriosis, mild endometriosis should not be treated because it has no significant benefit. But in other times where the endometriosis is causing deterioration of the change of the anatomy in pathological manner, you can remove the endometriotic tissues and then get the restore the anatomy back, in terms increase the fertility rate of a subfertility woman. Endometric surgery also depend on a few factors: the patient's age, the severity of endometriosis, the other symptoms, and and also the ovarian reserve, where you do the AMHO, the antral follicle count, and if there's no ovarian reserve, and then of course you must make sure that remaining endometrial tissues in the ovarian tissue should be preserved well during the surgery. We do still yeah. Yes. Howard. Endometriosis, the endometriomas can be removed or resected by the laparoscopy and can be surgically done. And also when you remove the endometrial mass, of course, you will lose a fair amount of good endometrial tissue as well. And so there are centers where the endometrials have been removed with minimal damage using the lasers and all. But in a case like this, where the endometriosis and the other symptoms are persisting, like pelvic pain and dyspareunia and all, you need a good laparoscopic surgery to remove the endometriosis, not only the endometrial mass, the other tissues as well. And when you do in the patients, yeah. Yeah. There's some connection problem here. Yes. So is it okay now? Is it something when you need? All right. Okay. Did you put videos and all, then the more technical problems are coming up. So here the endometriosis is all over, and it's you can see a big, large endometriotic nodule, which is there in the pouch of Douglas, and also the ovaries and the tubes and all are matted together. In kind of this kind of situation, the pregnancy is really is I think it's impossible here. Is all tubes are being matted together here. So the first of all, in doing endometriosis, you must make sure where your ureters are, because most of the time these endometriotic patches or nodules are just above the ureters, and you can see, if you could see the arrow here. And first of all, I dissected the ureter out, and then dissected the ureter under the endometriotic nodule, which is extending from the ovary to the pouch of Douglas to the other uterosacrals and attached here to the bowel as well. And very carefully you can lift the endometriotic tissue out, and with some scissor and the blunt dissection, get the plane out, and then dissect the ureter away, and then you can remove the endometrial tissue without causing any damage to the ureters. Here, this is the endometrial nodule, and it's a part of ovarian tissue is also there. And it's in case if you do not dissect the ureters properly, if you pull it out, obviously you will get a part of a ureter to your specimen. So then take some time, and need good assistance also. And clearly, you must make sure the ureters are well away from your dissection fields. And then you go to the other side and do the same. And after that, to take the tissues in the pouch of Douglas, here I dissected the ureter on the other side as well. You have to go to the pararectal space. It's the easiest place is selecting a virgin peritoneum next to your the sacral promontory, and on the right side, we usually do not see adhesions. And then once you lift the peritoneum and then go into the correct plane, where you find a lot of fat tissue, and it's easy to separate the pararectal fat from the peritoneum above, which always there's a plane, because in this plane you don't get any blood vessels, and also if you just pull your bowels away from the line where you dissect, and then you don't injure anything there. So you just go next to the bowel and in that plane. If you go more laterally, they won't be able to separate the bowel because the lateral pelvic wall doesn't have that plane. Identify the pararectal space is a one major principle, or maybe something that you have to practice in doing the laparoscopic surgeries. And then once you come to here, I show you here. Yeah, come to the level of the uterosacrus. Of course, you can separate the endometriotic tissues from the paravaginal tissue, going into the space between the rectum and the vagina. And once you get one plane there with some traction and the contraction, with some gentle shaft dissection, can pull or separate the bowel away from the endometriotic tissues, in which where you can remove all the endometriotic tissue in this kind of surgery. And here, just because of the time factor, I'm going through this. Yeah, after that, this is you can remove all these endometrial tissues by using monopolar. And if you see this space, your bowel and everything is well away from your specimen now. So you can cut from here up to here, and then take all the endometrial tissue. And one important thing is here, if you do the ureteric dissection and if you did the pelvic dissection, you must make sure you take all the endometriotic tissues at once, because it might not be easy to operate for the second time. And because ureters can get attached to the peritoneum, and when you do the surgery, and you must make sure that you take all the endometrial tissue in that surgery properly. And I have seen a few patients for the second time when we operated for a different reason, or maybe some recurrent endometriosis. These peritoneum, the new peritoneum which comes up, covering the areas that where we took the endometrial tissues, are nicely grown without any signs of adhesions or any sorts of new endometriosis. So in when you're doing the endometric surgeries, that all the endometrial tissue should be resected with care, and so that will give the best result. So after the surgery, this tube is here, and this side, that was hydrosalpinx, which we have already removed. Ovarian tissues are here, that endometrium, and this side also there was a previous surgery to remove the ovarian cysts, so the ovarian tissues are very less. But of course, the patient's symptoms would improve a lot after removing endometrium in this manner. And then can you get that video? Fibroid, make that. Make. This yeah. Yeah, this is a fibroid, but it's submucosal. But you would see the size of it, and came from the submucosal tissues and protruding into the cavity, and at the part of just above the at level of just above the cervical inner cervical opening. So even though it's submucosal, the video I'm showing here is, I don't think these size of fibroids could be taken by the hysteroscopic resection easily. and also the damage which could cause during the hysteroscopic surgery is more than you remove it laparoscopically. Here, you open up and then from posterior wall, and then remove the fibroid laparoscopically. And so then before you start in any fibroid surgeries, it's a must that you do your own ultrasound scans, because once you go in, sometimes you might not be able to trace all the fibroids. The guidance the memory that you had had at the time you're doing the scans only, which help you to find out the fibroids in case of where you can't see it from outside. And do it once, and just before the surgery also I do, and then I know if there's anything, if I couldn't see at the time of surgery, I can remember there was a fibroid here. Then during the operation also, sometimes I use the scan, and then that helps to identify fibroids which are there, but still couldn't see from naked eye, like in the sense from the hysteroscopy, because they are embedded, or like they are situated deep in the myometrium. So you do it and then you prepare it, and then so the other thing, the laparoscopic myomectomies, they heal very fast. A couple of patients I had, they virtually they got pregnant next cycle, and next menstrual cycle, and that was about a few years ago. But I was wondering whether anything could happen. It was due to the healing could have been that good, but still nothing happened. They heal very fast and they get pregnant very fast. Oh, next video. Yeah. Lastly, this is about a patient with a lot of adhesions, hydrosalpinges, and everything. Sometimes you might come across bowel adhesions due to the previous. Yeah, bowel adhesions due to previous surgeries, and then with careful dissection, probably you can remove the adhesions. And the serosal damage to the small bowel, of course, you don't have to do anything, but in this case, we had to put a few stitches to make sure that there won't be any bulging of the mucosa through these gaps. And once you remove the adhesions, then you go to a place where you don't find any uterus or ovaries, only the anterior wall is visible. Pelvis is whole covered with bowel adhesions. The few steps which you could guide. First thing, you have to identify which is which, and whether it's a small bowel or the large bowel. So then, first of all, you dissect all the small bowels and pull them out of the pelvis, and then you let only the sigmoid colon is there in the pelvis. Then you know that you are not meddling with the small bowels. And then lateralization, the medialization of the large bowel, you start from the left side, And you know, the bowel, large bowel, the sigmoid colon is, you still just want to finish this. Yeah. Yeah, here in this area. Once you, if you see the additions superficially, you can dissect them up to a level. You can identify the sigmoid colon properly, the directions of the sigmoid colon. Then you open up in this space where you get the mobilization of the sigmoid colon, and then you bring it to the middle, and yeah, it takes, yeah. So once you take the bowel into the middle, and you will find your ovaries and the tubes here attached to your the already mobilized bowel, then you can dissect it and get that plane. And then yeah, so this is because I just edited this video. Yeah, this is ovary and the hydrosalpinx. With some pulling and pushing, you may identify the bowel tissues and then remove them from the the reproductive organs. And so this is the enlarged tube that it took some time to identify the tube separated from the bowel. And once you get into the planes, you just pull it up, and then with these flimsy adhesions, you can cut it through and then separate them. Right. So then next steps is to identify the ureters at this space, and then take this bowel away and get all the sigmoid colon into the middle, and then get into the uterine plane, and then dissect the ureters, and just going through this, and then you will be able to dissect rest of the bowel adhesions. In this case, like in this case here, it's all been dissected to the rectovaginal space, and the ureters have been dissected from the either sides, and uterosacrals were identified, either one ureter on the left side, and then only you will identify the adhesions like any hydrosalpinx to be removed, and you slowly and carefully separate in from the vital organs from ureter and from the vascular structures from the pelvis. And then the bleeding is a problem, but still you can handle it with bipolar mainly. And then you remove adhesions, and then at the end this is endometric tissue, not much exist in here, but some previous additions were there. Like that, you correct the anatomy, and then you make the patient ready for the IVF. So finally, this laparoscopic surgery is something, of course, could be used with of paramount importance to improve the fertility rate in IVF patient where there's a problems in anatomical problem, like where there is a anatomical correction is needed, and you need some experience, but we all will take some time to learn some dissections and the tissue planes, but we all can perform this. And with the help of, sometimes we might need of our surgical colleagues, and especially in the endometriotic surgeries where the bowels are tightly adhered, and better to have them around than, to avoid the litigation problems. But still, if you do it correctly, and then that will be beneficial for the patients, as well as we can improve our fertility rates in ART patients. Thank you.
Professor Nishendra, there are 3 questions for you or more, I think, on the chat. Can we open the chat, please? I think the first question is for
Yes.
Dara.
Yeah, for you, rebuild reconstruction.
What is chance of ectopic pregnancy in tubal reconstruction? So in tubal reconstruction, the ectopic pregnancy rate slightly increased, not massively. I would say around maybe like 3 to 6%, but that also depends on the type of the surgery as well as how difficult the surgery is. And the next question is for Professor Nishendra.
Yeah, IUCD after, what is TCRF? Right, okay. No, it's not, it's only for the adhesions, adhesiolysis where you remove, I'm not quite sure whether Udara must have, when the places where you work, no, yeah, exactly. And where I used to work, like it's not, there was a fertility surgeon and he said, if you, I don't know, this is something which I didn't agree with him. And if you see additions and no, it's fibroid, yeah. If you have multiple fibroid, you do one side first and then don't do the other side. There's a risk of that scar comes and get adhered to the other scar. Like if you have fibroids in the anterior wall as in the posterior wall, and do the anterior wall first and then a later day do it on the posterior wall. But when I saw this question that came into my mind, so I thought I was not that I haven't seen anything like that in anywhere. But different surgeons, they practice different methods, but we all have to take little clues from different surgeons. And it's not a must always. Use of adenomyectomy. Adenomyectomy was done and it actually could remove some part of the adenomyomas and by in turn it reduce the pressure into the cavity and then can correct the anatomy. But by far the adenomyosis is the worst nightmare a fertility specialist could see or go through because it has very low fertility rates. And even though adenomyectomies were performed with laparoscopically or openly, in my experience, even though the uterus come back to near normal shape, still the pregnancies did not take place in many patients. When you compare in the patient who had fibroid removal, and the correction comes back because they have normal myometrium. Here the adenomyomas were removed, but the rest of the myometrium also adenomyotic. So there is a problem with whole uterus, not only that removing the pressure and adenomyectomy. Pararectal space that is the space we can separate the endometriosis from uterosacrals, from bowels. That is place where we can go and separate endometrium from the uterosacrals if it's attached to the rectum and the sigmoid colon. So that's the only place we can go through without a fear. In the pararectal space, you have a lot of fat tissue and you can identify easily the space. So once you, it's like going through a tunnel and you go through the tunnel and then you separate all the vital structures and then you know your roof is there's no bubble on your roof of the tunnel. So then you can cut through the roof. So that is the advantage. ovarian tissue damage is anyway. Other one, the zone 3 instead of zone 1. I don't get that question. What is that? Yeah. Is there anything like that? I mean, I don't know about it. Someone you know? Ah, okay. Ah, hmm. No, I'm not aware about it. Sorry. And the only thing I knew was in some centers in Europe, and they do not remove the if the patient is AMH levels are very low and the antral follicle counts are low, they just open it up and then so use the laser, and laser conserve a lot of ovarian tissue.
In my experience also. Can you hear me?
Yeah.
So I mean, unless the endometriosis is like severe or the person is having big endometriomas, we usually don't offer it if the patient is waiting for IVF. So it's like if it's like 5 centimeters or less than that, then we tend to offer IVF. We have different protocols. So, I mean, we tend to use a protocol called long protocol, and that will also downregulate the endometrial tissue. So the inflammation is less. And what the argument is that if you do a surgery, then the endometrial tissue is anyway getting damaged. So that could have a significant impact on the number of eggs we collect. So if we can collect the eggs and form the embryos, and then if the patient is willing, then you can go for surgery and remove the endometrium. But I think in UK, in the center I practice, they even didn't do the surgery unless it is significant. I mean, like if it's like 3-4 grade endometriosis or the patient is symptomatic, then only they get the gynecological opinion. Otherwise, they tend to offer IVF even, I mean, for the smaller ones. Yeah, that of course, again, I mean, what they used to do is they have a multidisciplinary team. Even for 5, they prefer not to go for surgery.
Udara, do you in many, like in some patients where they come and then we know that there are some endometriomas, then we used to aspirate it before the IVF procedure. But in X-ray, then there's a lecture, so I said we aspirated, we used to aspirate, that they didn't accept, and it was not a accepted method of treatment them. So then I asked why. So these results are not good, and some good additions could happen. But I think if your endometriomas are very like more than 5 centimeters, still not in a position to remove, then can aspiration by aspiration. I think there are more follicles could be harvested at the time of
So
IVF.
we used to aspirate at the time of the egg retrieval. Like if the endometrium is blocking the normal tissue, we used to aspirate the endometrium first and then change the needle and go and retrieve the eggs. I have seen that in the center.
Right, that we do. I mean, like if a patients come to the IVF with endometriomas and then before the IVF procedure, do you do?
No, we didn't do.
This one, can you get morbidly adhered placenta following scratching? Not that I know of, because it touches only the endometrium, and gives some stimulation to the endometrium, and the benefit will be there, they say, about for 3 months. But there are no, I'm not quite sure. I haven't heard of any reported cases. Femoral cyst, if you find it during the surgery, you remove, otherwise not. Okay.
Any more questions? So we have come to the end of our webinar today. On behalf of the SLCOG, it is again my privilege to propose the vote of thanks for this hybrid lecture, which is of course the fifth in our series of webinars that we have arranged to enhance the knowledge on various topics across the field of obstetrics and gynecology. So firstly, I would like to extend my sincere gratitude to our two distinguished speakers for today, Professor Nishendra Karunaratne and Dr. Udara Jayawardena, who have spared their invaluable time to grace this occasion and enlighten us with their expertise on the respective subjects. Thank you to both of you for clearing the concepts and enhancing our understanding about the management of subfertility. I would next like to express my gratitude to our sponsors, Mr. Gihan Lochana San, Country Head, Bharat Serums and Vaccines Limited, India, and Mr. Praveen Herath, Business Manager, Sioka Health Private Limited, for once again sponsoring today's event. Their generous support has made this educational webinar series a great success. Also, this vote of thanks would be largely incomplete without expressing my gratitude for all the staff members of the SLCOG and my team at Sri Jayawardenapura General Hospital who have worked hard in coordinating and organizing this hybrid webinar series. So thank you to you all. And finally, I would like to thank all the participants who are gathered here physically, as well as those who have joined online. I really hope today's lectures were useful in updating your knowledge in the management of subfertility. Thank you once again. And for those who are present here, there are some refreshments arranged on the ground floor. Have a good evening.